questions.
All right.
And then I can do the quick introduction beforehand.
All right. You have a pointer? This
I think that works as a laser pointer.
is it?
I thought it does. Or maybe it shows it on the screen, actually.
How would that work?
I'm not 100% because I'm seeing it pop up there. It's weird. Oh no, that's to move it.
Oh,
I'm
oh, I think. Yeah, that's weird. Okay.
it's like the mouse, so that's interesting. Okay.
Okay.
Yeah. They can be a sponsor institution, but it's still through demonstrated. They do most of our second time.
I'm saying.
I mean, it's going to become just fine.
Yeah, that's what I thought.
But I'm not anywhere close to that being the
All right, everyone, start sitting down. All right. Dr. G. All right, so we have a guest lecturer today to really help us out with the radiology because we could really use the help. This is Dr. Stephen Waite. He's clinical associate professor of radiology and internal medicine here at SUNY Downstate Medical Center. He was fellowship trained in cardiovascular and thoracic imaging, and he has served as the chief of the cardiothoracic radiology since 2005. A nationally recognized NIH-funded researcher, Dr. Waite's work focuses on error and expertise in radiology, with a robust portfolio of publications exploring topics such as fatigue, perception, communication, and diagnostic accuracy. He is also a passionate advocate for healthcare equity and disparities in radiology, and has lectured and published widely in this critical area. Additionally, his expertise includes serving as a medical legal consultant and expert witness in radiology-related cases. Beyond his academic and research accomplishments, Dr. Waite has been a driving force behind quality improvement, clinical operations, and medical education at Downstate. We are honored to have him here today with us.
Thank you, guys. So I think this is long overdue. I had an idea a long time ago that it'd be useful if you guys understood more radiology and we communicated better. So I'm happy to be here today. The goals are a systematic way of approaching imaging, and review some anatomy and show some cases. And I wanted to start with, I'm actually giving a talk about this at the American Ranking Society in May, mid-May, about error in radiology. It's something, believe it or not, before 1950, the assumption was that radiologists didn't make mistakes at all. There were no papers on radiology accuracy at all until this guy Garland did a couple studies, and he found the experienced radiologist. He was actually studying tuberculosis. It's actually interesting. He wanted to find out what's the best way to determine tuberculosis. If a film, or if you print it out, in 1950, they didn't know what to do. So he showed a bunch of radiologists films, and he was shocked to realize that they didn't agree with each other and they didn't agree with themselves. So if you show radiologists the same case at different points in time, they disagree with themselves 20% of the time. And we disagree with each other about 30% of the time. So he was like, well, that's a problem. So we've since then, the consensus opinion is that radiologists miss 3.5 to 4% of cases in daily practice with a mixture of normal and abnormal cases. We're very good at normal. But if you just show radiologists abnormal cases, we actually, you don't tell us anything, we actually miss a lot. You'd be surprised how much we miss. And there are numerous types and reasons for error. The most common is so-called misfinding, right? Failure to diagnose. And that's actually the most common cause of medical legal cases in radiology. Just so you guys know, the 3 most common lawsuits in radiology are failure to diagnose breast cancer, so mammography. 2 is missed fractures anywhere in the body, vertebral and non-spinal. And 3 is missed lung nodules. So hopefully the idea is that if you have, you guys are second pair of eyes and you know what's going on, maybe we'll decrease the error rate because it's not great. So here's a checklist of things we should look, we kind of at least try to look for. A patient name, position, technical quality of the study. Look at the tissues, abdomen, bones, mediastinum, hilum in the lungs, and pleura. All right. So I thought I'd start with case 1. This is a case conference. It's supposed to be interactive as much as possible. So this is the first case, and I'm curious, do you guys see anything? Any thoughts about this? What? What is that? Thank you. Do you realize how many radiologists I showed this to? And they have they sit there and they're like, whoa, there's edema here. I'm like, this is a baby. This is no. No, it's embarrassing because this actually was from county. I didn't make this up. I didn't violate HIPAA. It's the exact same name, medical record number, accession number, and basic time exam, except this is an adult, this is a baby. So the first thing I tried to tell residents, I showed them, I'm like, come on, guys, you can't even, I mean, one's a baby, we should kind of notice that. Maybe that's a problem. So the first thing is make sure it's the correct patient. You'd be surprised how often techs do stuff like this. The same name, obviously something's wrong here. So I thought I'd start with that. So here's a case. My wife just called me, I ignore her. But here's a chest x-ray, penile lateral chest x-ray. Any thoughts? By the way, this is not necessarily easy. I showed it to my first year residents and they think it's normal, but it's not normal. So here's a, theoretically you could look for the bones, look at the lungs, the outer vessel sharp, is the silhouette, the outer vessel silhouetted. I should hit the lights. Can I hit the lights? Yeah. We're creatures in the dark, so we can't, mediastinum, cardiac, look at the heart size, is any weird bulging, contour, look at the pleura, and look at the abdomen. Anybody? Well, what I did was I actually anticipating no one would see anything. I put a normal here. So this is the case, and this is the normal. Any difference? Yeah, sort of. I guess you call me a sound widening. So there's this stuff here, right? If you look here, it's not over here, right? So what is that? That's what you're. Also, one thing you'd be surprised how often people mistake what the aorta is. You follow that up, that's the periodic stripe. So the aorta is actually here somewhere. This bulge is actually not the aorta. It's extra bulge. You see that? Like, you see how the knob continues down here. So if this were the aorta, you see a line coming down here, but you don't see that because it's not the aorta. I have a lateral view here, which no one knows how to read, right? And I don't think chest people, I don't think a lot of our residents know how to read very well either. But anybody? It's a little harder, right? People don't understand lateral view, but maybe if you look at this, you see this area here is like kind of empty, but here it's not empty. There's stuff here. And also behind this structure here, there's this white stuff, and it's kind of like there's no white stuff here. So we'll go through this. So a little anatomy review. The abnormality is the mediastinum. So this is called the right pec. There's a in radiology, we talk about lines and stripes. Basically, we see differences in density. The only reason you see the heart, by the way, is because the heart is like tissue density next to lung, which is lung density, therefore you see interface, okay? I just want you to understand that basic concept. So when you have pneumonia, let's say you have the lung is, the air is replaced by something else. Blood, pus, fluid, cells, coordination material, something like that. It will become basically tissue density, and if it's next to the heart, will obscure the heart. And that's called a silhouette sign. You guys always should be called de-silhouette, but it's called silhouette sign. And that's how they talk about its structure silhouetted. It's basically if you have two structures the same density, you can't see the interface between them. So, and we know the right heart border is next to the right middle lobe. Therefore, if you have a passage obscuring the right heart border is in the right middle lobe. That's all we're doing. That's, as far as location, all right? So as I told you, that's the aorta is actually, that is not the aorta. It's some kind of extra density here. It shouldn't be there. So the right paratracheal stripe is actually this thin, you have the trachea. It's supposed to be a thin stripe, and what is that? That's the wall of the trachea. If you have something to the right of it that's obscuring it, it's because you have adenopathy or something next to it. That shouldn't be there. So this density should not be present at all. And if it's normal, again, right paratracheal stripe, normal finding right tracheal wall, just because it's silhouette because of the air of the trachea and the lung. So, and it's supposed to be less than 4 millimeters. All right. So here's a lateral view in a normal person. And you notice this area here is sort of empty, and it's called an inferior hilar window. Not supposed to be much down. And quite frankly, there's also not supposed to be much behind here either. This line is called, it's the posterior wall of bronchus and medius, and it should be relatively avascular. So this is from a book. They call this triangle lucidity, they call it inferior hilar or pulmonary window. And so it should be empty here. You have the right hilar vessels here, you have the left hilar vessels going back here, and this should be empty. So this is a case from the book of person with sarcoid. Instead, they have a ring, like a ring of density, and that's abnormal. And you'd be surprised how often we miss hilar adenopathy. So again, here's our case, and here's the normal. Do you guys see the difference? You see how it's empty here, black, and here's not empty, it's white. You guys see that? Right. And also you see this stuff posterior to the trachea, and it should be relatively lucent. So based on hilar adenopathy. So what could this be? Well, sarcoid, cancer, you might have, believe it or not, you can have lung cancer and not see a parenchymal density, at least on the chest X-ray. So, you think, especially in the right, age population, supposed to be about sarcoidosis, which is what this was. So here's a CT, you can see this adenopathy, this black stuff. So just to be really, really sort of basic, how do I know this is a vessel? I know it's a vessel because we put, we give people contrast. And just for you guys' knowledge, contrast is iodinated. So we actually give people iodine, and iodine is dense, and denser things are white on a CAT scan. That's really it. So bones white, the vessels are white because we made it white. The bones are white, and the vessels are white as well, in the lung parenchyma itself is white. So we can say these aren't vessels because they don't enhance with contrast. And that's what we're doing when we give contrast, by the way. Even without contrast, we should be able to see. So the reason we could tell something's a node is because of location and density. So even without contrast, I know that there shouldn't be anything to the left. This should be fat, but this is not fat density. That's fat density. So this is whiter than that, so it's not fat. So I know this shouldn't be here. Even without contrast, I would be able to say there's adenopathy. Now here's another case. I just put this for really demonstration of something that's normal. So here you can really see the right. Okay. Anyway, I'll just do it from here. Here you can see the right paratracheal stripe. Can you guys see my cursor? Oh. Okay, it's not working. Here to right is the next slide. Anyhow, anyway, the white arrow is pointing to the right paratracheal stripe. I don't know why it's not working anymore. Pointer. Okay. Anyway, so in this case, it's actually normal. You see how the blue arrows is a density to the right of the trachea, except it's like you see through it, it's not as dense as the arch, and you still see right character. Right, that's normal SVC. So I had to, after years of trying to figure out how I could tell the difference between the SVC and, abnormality, right paratracheal stripe, I realized that the SVC is not that dense. There's no mass effect in the trachea, and it has sort of straight but non-convex borders. If I see bulging to either the trachea is deviated or bulging laterally, then maybe it's adenopathy and not the normal SVC. Another case, some we see all the time, right? So there's there's arrow pointing to dot. What is that? What would you call that? The nodule, right? So it's a simple thing, but what's the definition of nodule? This is the kind of thing to ask my residents. You'd be surprised how often people don't understand. They just use words, but they don't know what the meaning of the words are. Anybody have an idea what a nodule is? It seems simple, right? What'd you say? Size cutoff? Well, that's part of it, but not entirely. Like if you have a line, they don't call it a nodule, right? So it's defined, actually, definition is defined as a relatively round elliptical opacity, at least partially surrounded by lung, less than 3 centimeters. That's actually the definition of a nodule. And you can see how it can be confusing because there's some line between something that's, if you have it too elongated, we don't call it nodule anymore, but it's a very weak definition if you think about it. Like, what does it become of opacity to nodule? And this actually is the source of medical legal issues, actually, believe it or not. And if it's over 3 centimeters, we call it a mass. Why 3? Because we made it up. We could have said 2, but people decided 3 centimeters. So the question is, whenever we see a nodule, we ask, well, what is the next step? What do you do about it? Anybody? Yeah, right. That's sort of the answer people give, but the real answer in radiology is old studies. That actually is always the answer, old studies. So it was there before. Let's see, 2022, 4 years ago it was there. So it's probably benign. So basically, they've done studies showing that this is one study. If you essentially, if you see a well-defined nodule less than about 6 or 7 millimeters on a chest X-ray, it's like always benign. It's basically a calcified granuloma is what this is. So I know in this case, I know it's unchanged at 4 years, well-defined, dense, calcified granuloma. You don't have to do a CAT scan. You can just spare this person radiation. I don't know if you guys saw it. It was a recent paper in JAMA Internal Medicine. Did you guys see that paper? They said the CAT scans are projected to account for 5% of all cancers in the future. Because people don't understand how many CAT scans we do in America. Any idea how many CAT scans are performed in America? What's that? Yeah, actually, before that paper, I've been telling people there's 100 million CAT scans, which is insane because we have a population in the United States of 350 million people. We managed to do 100 million CAT scans. And that's not, by the way, MRIs. We did 40 million MRIs in 2016, 275 million plain films at least. No one knows how many ultrasounds. We just image people in every way possible. We just keep imaging people. And it's quite frankly not getting any better. It's getting worse and worse. I'm actually sure that there are trends going on that's going to make it worse. But whatever. So I guess we'll just see what happens. Well, because this is the way we are in America. We just like imaging people. That's it. I mean, and it's not like radiology where we like it too. It gives us jobs, right? So until AI takes our jobs, that's a whole other issue. So here's another nodule, right? Do you guys see that nodule? My pointer doesn't work, fortunately. That. Okay. So what would you call this? It's a nodule, but anything else about this nodule? You guys see? Correct. It has this density. It looks like it has internally it's even denser than outside. It looks like it's denser inside. Where would you locate it? Like, where is it? What'd you say? Yeah. So where would you call it? What lobe? So I'll just go through that. So I thought it'd be useful to go through. I remember my second day of first week of radiology, I thought, oh, these radiologists are stupid. I thought, oh, I could just say a nodule's here, is right in the lobe, up here's upper lobe, here's lower lobe. What is all this? I realized I was just being stupid because believe it or not, the lobes it doesn't work like that. The major fissure goes to T5. So you get a lesion all the way up. You get a lesion all the way up here in this lower lobe. It's just the way it works. You can't assume there's something, oh, it's in the middle lung, therefore it's middle lobe. It just simply doesn't work like that. The craniocaudal location doesn't translate into lobes. which makes no sense, but that's the way it is. The lower lobe goes all the way up here to T5. So basically, if you have something anterior to the major fissure, it's on the left, there's no left lobe. So it's all left upper lobe. The lingual is technically part of left upper lobe, right? Anyway, on the right side, there's a middle lobe. So you inferior to the, if this anterior to the major fissure and inferior to the minor fissure, it's right middle lobe. And that's how we can localize what things are. So something like this. Well, let's see, I put a diagram here. So it's sort of lower lung, it's certainly the upper lung, the middle lung, and it's anterior to minor fissure, to major fissure, therefore it's right middle lobe. That's it. So what I do, what I didn't, this from a book, and this is what people do sometimes. They say upper lung zone, mid lung zone, lower lung zone. I don't do that anymore. I used to do that. My colleagues tell me, why do you just say zone? Just say upper lung. So I'll say upper lung, mid lung, lower lung. Notice I don't say lobe because I don't know what lobe. I have no idea what lobe is in. If it's a nodule here, I don't know. I don't know it's middle lobe. I have no idea. Unless it's silhouetting a structure, then maybe you could get a guess, but you can't tell. So you just say, I say upper lung, mid lung, base, or lower zone, if you want to say that. This is more for radiologists, but there are certain terms that for some reason chest radiologists hate. One is infiltrate. Radiologists don't say that word. You guys can say that all you want, but radiologists don't say that word in general. And I can tell you why, actually. And another word is fields. They're like the use of lung fields is inexcusable. So I don't know. I didn't say this from a paper a long time ago. Any idea why the word people don't shy away from the word infiltrate nowadays? I'll tell you actually, because it's actually important. It's actually important for you guys to understand. In radiology, there are descriptors and inferences, right? I didn't know in 1984, there's a group of radiologists called the Fleischer Society. You guys you've seen this in our reports, Fleischer Society. So a group of chest radiologists who sit and pontificate things, and that's what they do to make recommendations. In 1984, this group made a glossary of terms. And they said the term infiltrate should be condemned. And the reason they said that is actually interesting. They said there are two things, the description. If you say there's an opacity in an X-ray, everything is an opacity. Ribs are opacities, parts are opacity. It means the radio attenuates, some of the attenuates X-ray beams. If radiologists say there's an effusion or consolidation, we're inferring physiology from the description. We're saying that this opacity likely represents something in a physiologic sense, although we do not know that. Just understand that we actually don't know. If we see like pneumonia, I don't know what's pneumonia. I don't see cells. I don't see bacteria at all here. Oh, I could say there's an opacity. I don't know. I don't know it's pneumonia. So that's why we do this clinical, which I don't say. But the reason we all just say clinical correlated is because we actually literally do not know what things are. We see no opacities in the right lobe. That's it. And if you tell us the person has fever and a white count, then we're like, okay, it's likely to be pneumonia, but that's an inference. We're guessing or making an educated guess, but that's all radiology is. We actually don't know truth. The only people who know truth in medicine is pathologists, really. They're the only people, no, seriously, you just understand that because that's important to understand, just a philosophical thing. But we don't know. So we can describe things, but we make inferences, we're making a guess. So he did a study at Harvard. 4% of cases where radiologists said it was pneumonia, it wasn't pneumonia at all. It was either, inflammatory pneumonia, like organized pneumonia, or was cancer. We don't tell cancer what to look like. Maybe cancer looks like pneumonia sometimes. Matter of fact, low-grade adenocarcinoma, what these call bronchial carcinoma, looks like pneumonia. So rather than hedging all the time and saying, this could be this, we try to say, I don't ever say clinical correlate, but I say these findings could be pneumonia in the appropriate clinical scenario. Because we don't know. And unfortunately, we're in such a medical legal society that people feel need to give these battery diagnosis or say clinical correlation, which is obnoxious. So what's wrong with the word infiltrate? The word infiltrate is actually an inference. It came from pathology. Pathologists say that mononuclear cell infiltration of the spleen. So it's actually an inference, not a description. However, people have used it as a descriptor. They'll see any opacity in the chest X-ray and say it's an infiltrate. It's plural. It could be cancer and pneumonia. So did studies, 2005 did a study in radiology. They asked clinicians, what do you think radiologists mean when they say infiltrate? And the answer is, they don't know. And they asked radiologists, what do you mean when you say it? And we don't know. So we don't know what we're saying. And no one knows the word. No, we don't actually, people think it might mean pneumonia. But people don't actually know what it is we're saying. And we don't know exactly what we're saying. So they say it's a form of slang. So we should probably not say it at all. We should say opacity if we, if we're just saying it's non-specific opacity, we say that. If we think it's a fusion, we say it's a fusion or something more specific, or just say opacity is a general descriptor rather than saying infiltrate, which has a meaning no one understands, if that makes any sense. So it's an inferential conclusion used as a descriptor. Basically, that's the problem with term infiltrate. So if you look at any modern glossary, the Fleischer Society has like two. They always say, they don't even mention word infiltrate at all. If they do, they say it's not a preferred term anymore. And it's all the, so basically that's the reason we kind of don't shy away from the term, because we don't know what it is we're saying. If that makes any sense. So back to the case, the nodule has this internal density, which someone said correctly is calcification. And if you look at that, I put a green line. That's actually where the fissure is. So we could say it's left upper lobe, correct. So here's the next step. Okay, we got a CAT scan. Now this is too big to blow off. So here's the CAT scan. So then I want to teach you guys how we kind of think about these nodules. So this nodule has its internal calcification. Okay, well that's something else. So CAT scan, when we do a CAT scan for nodules, we put nodules into 3 buckets, really. Definitively benign means there's benign characteristics of the nodule and no other malignant characteristics. If you think you see central calcification or popcorn calcification in a nodule that's spiculated, you better call it malignant. So it has to have no malignant characteristics. Probably malignant. We can never say a nodule is malignant. We actually can't. Even if it's big and spiculated, it could be organized pneumonia, some infection. We don't know it's malignant. Or indeterminate, which means it has no specific malignant or benign characteristics. So these are benign patterns of calcification, smooth border. This has so-called popcorn calcification. It is therefore definitively benign. It is a hamartoma. Here's another nodule. Anybody know what this is? I put a circle around it. Here. Do you see it has partially sharp borders? What is that?
We see the other side.
Sure. Isn't that? It's a nipple. Well, how do you know it's a nipple? And I want to go through that actually. Believe it or not, there's actually a reason. One you correctly said it, there's bilaterality, which somebody asserted to, but it has partially sharp borders. That actually is a name for that. This is actually called the incomplete border sign, believe it or not. So basically the idea is this, in simple terms, imagine you have, oh, there it goes, I see. So either a nipple, this part is sharp because it's facing the lung, right? So you have soft tissue next to air. If it's the other side of it's, butting the chest wall, so therefore it's unsharp. Does that make any sense? So it's a matter of what it's next to. So if you have say a nipple, part of it's on the chest, obviously attached to the chest wall, and part of it's surrounding air. So therefore the part surrounding air is sharp and the other part isn't sharp. So basically, incomplete border sign, bilateral lower hemithorax, this nipple shadow, you do markers and you'll see what it is. Here's another case. This was actually missed by, the one thing I tell my residents, the most horrible thing to miss, I do a lot of, I do research on error, but I also do medical legal work and defense. I defend actually ER doctors and radiologists all the time. And to me, there's a few things that are like, it's hard to explain away to a jury. One is sloppiness. Like if you see, if radiologists see, if you see a nodule, a mass, I'll tell you medically the case I got. So a patient had CAT scan pelvis for a history of melanoma. Patient had it, and the patient had adenopathy, all these nodes, okay? The patient had another study 3 weeks later at the same institution. Somehow the radiologist missed all the nodes with a history that said swollen nodes. So he made multiple perceptual errors. Plus, he didn't look at the history. Plus, he didn't compare it to a study at the same institution. And then they did a PET scan, and somehow they did a PET scan, only did the legs, didn't do the chest. He said it was negative, which is true. I don't know why. So the clinicians thought it was a whole body PET scan, they only did the legs. I don't know why. So it's all kinds of wrong. How do you defend that? So you're from a jury, you're like, well, yeah, they just scan random body parts. No one knows why they're saying what they're saying. They don't look at old studies. They can't look. So it's all kinds of wrong on multiple levels. So to me, if you have a study and you see this here, there's lesion here. and then you miss it here, that's I'm sorry, that's inexcusable. So this person, they managed to miss this lung cancer on the later study and not the former study, which is to me horrible, because it means you not only miss it, you also don't bother looking at old studies. So I'll tell you that always look at old studies. Even if a radiologist doesn't do it, you should. In general, generally speaking, nothing, you don't really see anything. Superior hilum's kind of empty. If you look at the other side, there's really not much here, but you see this thing here. So that's what this was. It's lung cancer. All right, here's a basic case. Hopefully I get to some more case. I thought I was gonna start 11, but anybody? What'd you say? Correct, pneumothorax. So pneumothorax. All right, simple enough. So you guys know this, air collection in pleural space. Now, believe it or not, and especially in trauma like a county, you'll see this. Believe it or not, there's a lot of up to half of cases. If you look at the CT, they have pneumothoraces, you'll look at the chest screen, it's not there. And they call that so if you do a web search, PubMed search, occult pneumothorax, you'll see a lot of papers. A lot of it's in surgery literature. But it's also supine, they also call it supine pneumothorax, usually they're laying down, right? So a question that we get asked a lot is, well, how big is it? So this is very inaccurate because you're measuring a three-dimensional thing in 2 dimensions, but this is the way you would do it. You would average, you would take A, B, and C, divide by 3, and you get some kind of distance. And if the average intrapleural distance is 2 centimeters, you could say it's about 29% of the supine patient, but they say the size is less important than the physiologic status. And they've tried to make up rules, say, oh, if it's 2 centimeters on a CT, maybe that's different between large and small. So that's kind of the number we'll give if you ask. Here's another case. What do you guys think? On the left side. Pneumothorax, right? Do you guys think it's pneumothorax? It's not pneumothorax. And you'd be I remember there was a case at county a couple of years ago where they called pneumothorax, they put chest in there by causing pneumothorax. So if you have a case where you do something to somebody and you cause them to have a problem they didn't have before, it's a state reportable event. So this is not pneumothorax. This is called a skin fold. And I want you guys to see this because this is a mimic of pneumothorax. So left side pneumothorax. Well, number one, why is it pneumothorax? It disappears. If you follow this supposed line, you'll see it kind of trails off superiorly. It disappears. So skin folds disappear superiorly or inferiorly. 1. 2 is the normal markings outside of the so-called line. You see there's white stuff and white lines going past this supposed pneumothorax, which is not a thing because in pneumothorax, you don't have lung there, so there's no markings. 3, there's actually no line. If you actually take a look at this supposed line, you actually look at it, you don't see, there's no discrete line. So the interface, like sort of white is sort of black. So there's actually no discrete line if you actually really look at it. Like look here, there's no actual line here. So this is whitish and this is blackish, there's no line. So this is what they call a skin fold. And I think it's redundant tissue. I actually looked it up last night. Plastic surgery literature said the skin fold is skin redundancy in combination with connective tissue. You'll see this all the time. All the time, if you look, you'll see this kind of thing. And if you don't know, then you could do a CAT scan, I suppose, or you could just lay the person their right side down and you'll see if it's pneumothorax. But this is a common mimic. So you don't want to make this mistake, even if a radiologist does. Here's another case. This person has a problem and so this person has a lot of things: pneumothorax, new mediastinum, subcutaneous emphysema. All right. So I want to show you guys a CAT scan just to show you some basic stuff. So what do you think this blue arrow is? You see this blue, what is this? What is that? Correct. So it's actually, well, more basic than that. It enhances it with contrast. And since there's no vessels in the pleural space, the pleural doesn't enhance with fecal fluid. So we use enhancement pattern and the presence of volume loss to determine whether something's alexis. This could have been consolidation, but it's flat, it homogeneously enhances. That's to say, this sort of white's the same as, you can't even see my cursor again. This white is the same as that white. So it homogeneously enhances as volume loss. This is Alexis. This is not enhancing, it's outside the lung. This is an effusion. That's all. I just want to show you guys that. In another case, I'll do it myself. So you guys see this? Where? Right. Good. Yeah. So every case I tell the residents, look for pneumothorax, pneumomediastinum, pneumoperitoneum, and malposition lines and tubes. Those are things that get you in trouble. Like, because if you, I've seen cases where the tube is malpositioned, NG tube, and it's in the lung, and then they feed the patient. That's not great. Because then, again, it's a state reportable event. Why you feed, you're not supposed to have enteric feeds in your lung. It's not, good. There's a lawsuit, and it's a lawsuit you can't win because no one's gonna be like, well, that's perfectly okay. No, there's no. It's clearly below the standard of care, i.e., negligence is what it's called, right? So you see this white, this circle here. You see how this is sort of this homogeneous white? It's sort of this hazy white. I just want to show you this is what pleural effusion looks like. So when you lay down, pleural effusion has this sort of homogeneous veil-like density, but you don't have necessarily obscuration of the vascular markings. So you see this whitish stuff, you can see vessels through it. That's what a pleural effusion looks like when you lay down. I just want to show you a category of disease. So this stuff, do you see how this has this white-black? It looks like kind of like white-black, white-black, white-black. That's parenchymal disease. So I just want to show you that's what parenchymal disease looks like. Again, versus this, which looks like veil-like homogeneous, right? So this is effusion, this is in the lung. And if it's in the lung and it has volume loss, like say it's Alexis, otherwise this doesn't have always volume loss, so I'll say this consolidation. All right, so here's a case I'm going to show you. Here, anybody? So if you look at this opacity now versus the other opacity, okay, we have this pleural effusion, doesn't enhance, but this opacity looks like it's sort of like dark, and maybe some of this is a little bit, this enhanced a little bit more, and this has this bubbly appearance. But then I'm like, well, what is that? Do you see this? Any idea? This is what an infarct looks like. So it's a pulmonary embolism and infarct. So you have this filling defect, and then you have this lung that looks sort of bubbly, and that's what an infarct looks like. So again, Alexis homogeneous, enhances avidly, because what Alexis is collapsed lung, right? So if you took the air out the lung and it actually enhances avidly. The lung is very vascular. It just doesn't look that way because there's air in it. So the Alexis, if you move the air, enhances homogeneously very avidly. Consolidation, like pneumonia, looks more heterogeneous, and infarcts has this bubbly appearance. It just sort of, yeah. So you could mistake consolidation infarct, but it's sort of like this appearance where it looks this sort of bubbly thing in it, the orange arrow, is sort of the giveaway, especially in the setting of a pulmonary embolism. So I think I'll end with this. This is a case I had. This was the first medical legal case I actually ever had to defense. This was a rollover MVA. This is actually from Lutheran, and it's traumatic amputation of left arm. So this person had just chest X-ray. Anybody? So I think it's fair to say, right? There's mediastinal widening. I can't see the knob. The endotracheal tube's too high. Here's a CT scan. So this is where things get scary. This person had this CT scan and came off scan and died in a half hour. And they didn't make they made a lot of findings, but didn't make the relevant finding. And I talked to lawyers about this over the years, and I've come to realize there are certain arguments they'd like to make. There's certain arguments that are less ideal. If you have to make an argument, imagine you take 6 people who aren't doctors and you say, hey, they would have died anyway. There's a mistake made, but they would have died anyway. That sounds like, I don't know, like a feeble excuse, doesn't it really? If you're not a doctor and you say, this person would have died anyway, even though they missed this thing, they would have died anyway. That sounds like you're making an excuse, mainly because you are. So I think that's like not an ideal argument for them to make. They'd rather you not miss things in the first place. So anybody see anything on this? Well, I think I see this sort of, there's a aorta. I see this, I don't know, this stuff around the aorta. So maybe it's a hematoma. But here's the giveaway. Here's the CT scan, a little lower down. And once you notice the contour of the aorta, like what is this? Do you see that weird, like what is this thing? Do you guys see that on multiple slices? There's this weird contour deformity, like this, look, that's not normal. So that was missed. So this was a aortic laceration that was missed. And again, the patient died a half hour, but it was a lawsuit anyway. But it'd been better. I think they would have been better off if they said there was laceration and the patient died than saying, well, you missed the laceration, but they would have died anyway. So traumatic aortic injury, I thought it's appropriate to talk about that. It's a spectrum of injuries from trauma, intimal, from complete transection of the aorta, just intimal injury, like minimal aortic injury. And basically, they say that most people with aortic injury, they die on the field, right? So you get hit by a car or something, you die because you rupture the aorta at the root, then you die. If you make it to the ER, there's a very high if you do not diagnose this stuff, they die very rapidly if it's untreated. So it's important to notice. So there are these CT findings, mesothelioma hematoma is indirect finding, but if you change in caliber of the aorta, more regularity, abnormal contour, obviously contrast going out of it, those are more direct findings. So I thought just a little bit of anatomy. You have the aortic root and descending aorta. You have the arch, which goes actually to ligament arteriosum. Now, this is actually really important. It's funny because they don't even we don't talk about this much in radiology. This is called the isthmus. Just distal to the left subclavian artery, this is called the aortic isthmus. And it's a small area, but this is where like all the traumas, the damage to the aorta occurs. All right. So basically, because of this differential deceleration and it's tethered here, basically the injury occurs here. That's where the injury occurs. So they say 90% of injuries of the aorta, people make it to the ER, the aortic isthmus. So you really scrutinize that area as much as possible. I have one more case, looks like. So this is a case 7-7 and 7-8. Do you guys see a difference? Well, to me, that's pretty clear, and then now it's not clear. So within a day, this person developed this right-sided parenchymal disease. So it's acute consolidation, and things you're supposed to think about is aspiration if it's very quick, and hospital-acquired pneumonia if it takes a little longer. This was confirmed aspiration, and who had an event during aspiration event during catheterization. And I think, did I show more? Wow. Okay, one more. I'm sorry. This is actually used for you. I'm sorry. So anybody? Okay, that's always the answer people. That's usually the answer people give. That's correct in this case, but not really entirely correct way to describe things. No, I'll tell you why. It's because I chose the residents their answer to biliary TB. The problem is that asserts that all TB, you're asserting a diagnosis from imaging. You can have miliary cryptococcus, miliary histoplasmosis, miliary Mets. You can have other diseases that form dots. And if you say, I tell my residents, if you have a board examiner, our residents taking oral boards. And if you just look at that and they say miliary TB, if they're wrong, where do you go? You don't have any, you didn't give a description, therefore you're just asserting it's something. If it's not that thing, you don't have anything to fall back on because you made a presumptive clinical diagnosis based on the imaging findings where it's not specific for that thing. So miliary pattern, I agree. And it could be histoplasmosis, I have a case of that. Coccidiomycosis, malignancy also causes this kind of thing. The reason I'm showing this is because I want to differentiate that from this. Now, in this case, do you see, if you look at this case, what are the characteristics? It's like someone threw sand on the film. They're numerable nodules, they're non-countable, they're all less than centimeters, they're all about the same size. So this falls in the category of nodular pattern of interstitial lung disease, which miliary TB is a big cause. This, however, are multiple nodules too, but you see nodules of different sizes. Like this is big, this is smaller, variable size. So you have more countable, variable sizes, some over a centimeter. This is messed to proven otherwise. On top of that, of course, this person has pneumoperitoneum, and here's the CT, and they have some of these cavitaries. So this is Mets. So I want to show you the different patterns of nodules. There's this, and there's this, and they're different. That's it. Thank you, guys. Any questions?